All right. Hello. Welcome, everyone. Welcome. Letting folks in. Hi, everyone. My name is Vanessa Adams, Program Coordinator for Kids Mental Health, Pierce County. Really excited today for this program more than anything. So glad to have Dr. Lucas McIntyre here. Nicole, the social worker for the program, will be joining us. We officially have a Pierce County Adolescent Intensive Outpatient Program with MultiCare Behavioral Health. Very much needed. Very much excited for this. I'm going to turn it over to Lucas and Nicole when she joins and hear more about their program. Welcome.
All right. Thank you very much, Vanessa. Very excited to be joining everybody here and being able to bring this program to Pierce County. Let me go ahead and open up my presentation and get sharing my screen, and we will get started. Give me 1 second.
Couple housekeeping reminders while they go ahead and get started that we have the question and answer feature enabled and as well as the chat. So please feel free to use those and they'll get to those at the end. They're going to go through the presentation and at the end we will have time for questions. I see that Dr. McIntyre has his slides up and I'll turn it back over to you.
All right. Thank you very much, Vanessa. Sorry for the delay there. Yes, feel free to call me Lucas, or I also go by Dr. Mac. So we're very excited to share about the MultiCare Adolescent Intensive Outpatient Program. Myself, I'm the founding medical director. I am also a child and adolescent psychiatrist, and I'm joined by our program social worker, Nicole Nichols.
Hi, can everybody hear me? Can you hear me?
Yep, can hear you great.
Oh, okay, perfect. I just was switching my microphone there. So hi, yes, I am the program social worker here. I also do some therapy. So yeah, it's great to be here. Thank you, Vanessa.
All right, thank you, Nicole. So moving on. Okay, so a little bit of an overview here, and then we will break down each of these things as we go through our presentation. So to our knowledge, there's only one other intensive outpatient program here in Pierce County. And to our knowledge, we are the first program that is offering services for patients with Apple Health Medicaid. We take all Apple Health Medicaid except for United. So we do take Molina, Coordinated Care, CHPW, and we also take some commercial insurances, including First Choice and United Commercial. And we are working on taking more insurances. Our contracting team is working on that, and hopefully we'll be able to share a broader commercial payer mix in 2026. So to briefly go over our intensive outpatient program, we are a dialectical behavior therapy program for youth aged 13 to 18. And this is specifically for youth who are struggling with suicidal thoughts, depression, dysregulated emotions, self-harm behaviors. The program is 9 hours a week, Monday, Wednesdays, and Thursdays, and it goes for 12 weeks. And a brief overview of our services. There's a mental health evaluation by myself as a child and adolescent psychiatrist. I'll talk more about the details of that later. I also do provide medication management if that is needed or desired while youth is enrolled in the program. The majority of the program consists of group therapy. Youth are also provided with individual therapy. There's an individualized treatment plan, and we also offer a parent DBT skills group weekly. We are located in Lakewood at the Greater Lakes location. I'll turn it over to Nicole.
So I'll talk a bit about our admission criteria. We work with youth who are 13 to 18. I do get a lot of referral requests for youth under the age of 13, but our kiddos are 13. We're not licensed for 12 or under. And then as far as the 18-year-olds, it would be 18 who are still eligible to graduate from high school. So if they're in school or looking to get, re-engaged with school, possibly like Running Start or high school, yeah, up to 18 as long as they're eligible to graduate from high school or in that age area. So other admission criteria: depression, suicidality, self-harm behaviors. A lot of kids that have been, in and out of the hospital for suicidal ideation and emotional lability. So, yeah, so those are the kids that we are mostly getting referrals for.
Thank you, Nicole. And just to clarify, a youth doesn't have to have all of these symptoms. They may only have one or two. And really what we're looking at is the functional impairment that they're experiencing in their life related to these symptoms. And so with that in mind, if you are a community member thinking of referring a youth to our program, I think it's helpful to conceptualize where the IOP fits in the continuum of care. We typically think of traditional outpatient as quote unquote lower level of care, though I would argue that can be a higher level of care in terms of therapeutic results. And typically we think of inpatient psychiatric hospitalization as a high level of care, though I would argue it is a high level of care in terms of physical safety and things like that, though it may not necessarily be the most therapeutic environment. And so IOP fits this niche in between your traditional outpatient treatment, which is typically individual therapy once a week, maybe medication management once a month, and inpatient psychiatric hospitalization, which is typically 5 to 7 days on a locked unit, or residential treatment. And so IOP, I think of as either a step up from outpatient or a quote unquote step down from residential or inpatient treatment. So for example, if you are a community member, you're working with youth, let's say you're a therapist and you have a youth that you've been working with for a while and they're starting to be extra depressed, maybe they're starting to endorse some suicidal ideation, maybe they started to engage in self-harm, maybe they've gone to the emergency department. IOP is a great thing to consider if you're like, gosh, my kiddo is not getting the skills as quickly as maybe they need to help manage these behaviors or manage these emotions. Maybe going for 12 weeks in this intensive program can really shore that up for them. And so as a step up from outpatient, I think IOP is a really great option. Oftentimes, you can think of us if you are like, ooh, I don't quite know if kiddo is needing inpatient hospitalization, but they do need more, right? And so oftentimes IOP is a great way to prevent inpatient psychiatric hospitalization or even the need for residential treatment. So that's how I think of it as a step up. In terms of step down, oftentimes we will also get referrals for youth that have been in residential treatment. And so residential treatment typically is either out of state, or if you're in state, it's the CLIP program, the Child Long-Term Inpatient Program. And so typically they've been there for a month, couple months, 6 months, it's rarely up to a year. And they need to transition back to the community. And oftentimes that step from residential treatment back to the community and just doing traditional outpatient, that is a big step, right? Or let's say, for example, you've had a youth who has been admitted to the Tacoma General Adolescent Behavioral Health Unit or the Seattle Children's PBMU, and there's concern about them just going back to traditional outpatient. Maybe they're also somebody who needs a little extra support, and so again, that's another great time to think of IOP. As a step down, thinking of it as an extra step in that transition back to regular community engagement. And so when I think of a typical patient that is referred to us, they may have had multiple ED visits, typically for suicidality or self-harm. Maybe they have had 1 or 2 inpatient stays, maybe a residential treatment. For example, maybe they've been enrolled in WISE, or they're at risk for hospitalization. Another theme that we tend to see is kiddos that are either really highly sensitive or have really intense emotions. Maybe traditional therapy hasn't been working for them, or just quote unquote isn't enough. Maybe also these are kiddos where there's been a lot of different medications tried, and they just don't seem to be having an impact. And so that's another great time to think of referring to our intensive outpatient program.
Thank you, Dr. McIntyre. So now let's talk a little bit about the exclusionary criteria. So when a youth is experiencing active suicidal ideation, like they have intent, they have a plan, obviously they would need a higher level of care where they can keep themselves safe. So that's when we would be looking at, hospitalization, where we're not, we wouldn't be the proper level of care because we're not able, they would need to be somewhere where they can keep themselves safe. So that wouldn't be, we wouldn't be the right program for that. They would need to be able to go to the hospital first. And same with active homicidal ideation. So that's part of exclusionary criteria. Any violent or aggressive behaviors, or a history of violent or aggressive behaviors. Now, we do take a look at every referral on a person-to-person basis, but generally a history of or current violent or aggressive behaviors, especially towards if they've been in like a previous residential treatment or inpatient or an acute hospitalization, and they've been violent or aggressive towards staff or peers, then that would be exclusion criteria. But Dr. McIntyre takes a look at all the referrals. So if you have any questions about that, always reach out to me, and then we can answer that. And then any substance use disorder as a primary diagnosis where they would need substance use disorder treatment, we're not equipped to do that. That is not our primary, that's not our primary, what we do here. So we wouldn't be the most effective place for them. Now, that being said, some of our youth use substances as a secondary or other issue, other problem, and so we do look at every referral and every kiddo on a case-to-case basis. But if they have a primary diagnosis for substance use disorder, we wouldn't be the right program for them. Same with this, eating disorder is a primary diagnosis, especially if they needed, definitely a higher level of care of where they needed like a feeding tube or things like that. That we're not the program are able to help them. Or so I do have resources that people reach out to me, because I do often get, especially with substance use disorder, I do get people who are interested in the program, but we're not the right fit for them. And we do want them to get something out of attending our IOP and being able to participate in the DBT group. So if they're not able to participate in the 9 hours of group therapy a week, 3 hours a day, 3 days a week, then this isn't the right fit for them. And so we want them to be able to get something out of the groups, a lot of times when kiddos get here, they are slow to participate in groups, but we want them to, be able to, gain something from the program. And so the ability to participate in group is important. So that would be exclusionary criteria as well. So there are a couple, multiple things that might affect their ability to participate. So always reach out to me with questions regarding that. Yeah. Dr. McIntyre, do you have anything to add to that?
Yeah, thanks, Nicole. That was great. I really the exclusionary criteria is so that we can provide the best treatment for the youth that are enrolled in the program, because any of these exclusionary criteria can really interfere with the group setting and the group learning. And so, the active suicidal ideation as exclusionary criteria is there just to emphasize that we're not an emergency services program, right? So if there's an acute need, we're not able to help those youth. However, we do work with youth with, passive suicidal ideation, these kiddos that, are chronically suicidal, but, don't necessarily have an intent or plan that day. And so that is why that is there. And again, as Nicole said, we do what we do well, working with kiddos with, depression, suicidality, self-harm behaviors, but we are just not designed as a substance use disorder or eating disorder program. And so we don't want to misadvertise ourselves as providing dedicated treatment for that. But as Nicole said, many of the youth, will use cannabis or have experimented with alcohol. We're able to work with youth. And while many of our youth don't necessarily have a primary diagnosis of eating disorder, unfortunately, some of them do have disordered eating. And as long as it's not interfering with their ability to participate, typically that is not an issue. As Nicole said, I do review all of the referrals that are sent in. And so if you're on the fence about sending in a referral, as Nicole said, you can reach out to her and ask a question, or you can just send in the referral and we'll review it. And then in terms of being able to participate, sometimes people wonder, it's like, oh, if, a youth has autism or, a developmental disability, are they not able to participate? And as long as they are, we have many youth. We actually have quite a number. We have a number of youth right now with, autism spectrum disorder level 1. We have one youth in the program who has a genetic developmental disorder, and they're all able to participate, right? And so we also work a lot with neurodivergent youth and definitely welcome referrals for those youth. So just a little bit about our schedule. So currently we're designed as a 12-week program, Monday, Wednesday, and Thursday. And we have 2 cohorts currently available. So we have a noon to 3 p.m. cohort. So if a youth was enrolled, they would come here at noon on Monday, Wednesday, and Thursday. And then we have our most popular cohort at the moment, which is the 4 p.m. to 7 p.m. cohort. I say that these are currently available because if, for example, our noon to 3 p.m. cohort doesn't end up being very popular, we may end up doing away with that, maybe replacing it with outpatient DBT services or maybe other groups. But the 4 p.m. to 7 p.m. is very popular at the moment. I think everybody could probably understand why. It's very convenient in terms of being after school. In fact, when I was designing the schedule for this program, I busted out my Google Maps and I looked at some sample high schools and middle schools from different school districts in the area, and I figured out, okay, when is the end of day for the school, and how long would it take them to get to our location? And so that's where I came to the 4 p.m. time to give enough time for people to still be enrolled in school if they want to and be able to make it. And as noted, maximum group size for each of these cohorts is 10 youth each. And admissions are on a rolling basis. So don't feel like you have to wait to send in a referral. Send in that referral. We can see if we can get your kiddo in, or we'll let you know if there's a waiting list and how long that is estimated to be. And there's also a clinical advantage to having admissions on a rolling basis, because then we have youth in the program who are more senior that can take on a bit of a mentoring role for the youth that are just joining the program. Historically, in our previous program that we were running that was similar to this, we would even have youth that would take leadership roles and help run some groups and things like that. It becomes pretty fun when they can take some ownership.
All right, so the services that we provide are, as Dr. McIntyre mentioned in the beginning, he does a full psychiatric evaluation assessment and that's done actually at the intake appointment. So at the first intake assessment appointment when youth are coming in. So after I get the referral and we take a look at it, Dr. McIntyre takes a look at it, and a youth is admitted to the program or accepted, I reach out, I talk with families in depth, and I talk with every adolescent as well. To one thing that I wanted to mention, and Trevor's been mentioning it, is that youth have to be voluntary for the program, because again, it fits with them wanting to participate and engage. But I do talk with them to make sure that they know what the program consists of, and they're willing to participate and come. And so once that happens, I'll schedule the intake appointment. It is in person. I get asked a lot if they can do that virtually, and no, it's in person with Dr. McIntyre, because he does that psychiatric evaluation during that first appointment. And so, and we'll move quickly after that usually. We're getting so that we might have a wait list, but to beginning to start groups. So, but that is the process there. And so with groups, we have the DBT skills group therapy. And so, like we've said, it's three groups a day, 3 times a week, and we have a 15-minute break at the end of each group. During the groups, we do different activities, different art therapy, and we'll talk about this in a little bit, but the different core modules, core tenets of DBT. We offer individual therapy. Every teen has individual therapy with their individual therapist while they're here. That often happens during the group time during the week, but they are offered time on non-group days to come in for that as well. And then the parent DBT skills groups that meets on Tuesday evenings, and I'll talk more about that in a little bit as well. So that's offered for parents. It's not a requirement. They don't have to come for parent skills groups, but we do hope that parent and guardian will be able to attend the skills groups. And as Dr. McIntyre had mentioned, he offers medication management for if that's applicable, and consults or collaborates with any existing medication management that the youth has when they come in. So I, as a social worker, start discharge planning from the very beginning, working with any existing therapists. And I get we get asked this a lot. If a youth, if an adolescent has a therapist, a weekly therapist that they're seeing when they come here, I'm not sure if this was mentioned already. I don't think it was, but they're able to keep seeing their weekly therapist. The only thing is, if they come in and they have Y services, they're not able to continue, and I believe it's because of insurance purposes, with Y services and IOP at the same time. And so, but So that would be a choice to make, like whether they wanted to do IOP services and things with their WISE team, or however that would work. But if they do have a weekly therapist or somebody they're seeing for medication management, they can continue to see those clinicians, those providers at the same time as they're attending IOP. And we would just, consult with them and collaborate with them as the program goes along for the 12 weeks. But I start the discharge planning at the beginning, working with the team here, obviously the adolescent and the family, to make sure that there are appointments and everything set up at the end of the 12 weeks, so that there's not just nothing, like, okay, you graduated, you're discharged, and there's no appointments. They'll mention this again in a little bit, that they will have a step down as far as therapy or whatever is the next step for them, an appointment with their primary care, and an appointment with psychiatric medication management, if that applies. So yeah, and any other resources that they need or ask for during the time.
Great, thank you, Nicole. So just going through each of those pieces. So in terms of the psychiatric assessment, so oftentimes we'll get referrals and people will be like, okay, when can they start groups? And we have to be like, oh, hold on, let's slow down a little bit. We do need to do an intake assessment before starting groups. And that is done with myself. So I'll do a psychiatric assessment when they're enrolled in before they are enrolled in the program. And so, it's comprehensive. I review their psychiatric, medical, and social histories. I do a diagnostic interview with both the youth and guardian. We do also work with youth that do not want guardian involvement. Here in Washington State, youth age 13 or older can consent for their own mental health treatment, and we are open to working with youth on that. It is my preference, when possible, to include guardians or parents. Oftentimes they provide a different perspective and can be very helpful in terms of diagnosis and guiding treatment for youth that are enrolled in the program.
Great. So our curriculum is modeled after, actually it's based on the DBT skills manual for adolescents by Rothas and Miller. And so we've spent a lot of time creating our curriculum, like we continuously work on building it, revising it for the kiddos that come in, when we want to make it more it's very, I would say, cohort dependent, as far as, like, we have the rolling admissions, we have different kids coming in, and we continuously make that, although it's based on, we have our standing curriculum where we have alternate lessons for those days and the sessions. And so we're continuously updating that to make it more, I want to say, exciting, not just lecture, and more relevant why we're teaching the core skills. So, which are mindfulness. And so these are the core tenets of DBT. Mindfulness, emotional regulation, and I'll talk about these a little bit in a second. Distress tolerance and interpersonal effectiveness. And then specifically for adolescents, there is walking the middle path, which is part of interpersonal effectiveness. It's a way of making compromises in life, and it's really unique to adolescents, particularly with adolescents and their parents. So it's really helpful as we talk about the parent group. Something that we're also teaching the parents. I'll talk about the parent group in a moment. But I believe that mindfulness is really important, especially with teens who are just going and going and going and don't take time to be in the present moment. So we reiterate mindfulness throughout the 12 weeks to slow down. We talk about that a lot. so that they can use the other skills. So to slow down and be mindful so that they can apply another skill that they've learned. And I think with the teens that we're working with, the emotional regulation, when they have that emotional ability, is very important. There are several skills there that we teach, and the distress tolerance skills, because often, of course, they are so quick to make impulsive decisions without, being able to sit in that level of distress, because they just want to not. They don't. I think a lot of teens just want to, not feel that those uncomfortable, those yucky feelings, right? They want to just, and a lot of them just want to feel numb. And so being able to learn to have that distress tolerance and to sit in those feelings. So that's important too. And definitely the interpersonal effectiveness skills to work on relationships. And we also have, we also integrate with that being in the group, being a group program. I think it's really important to be in a group and learn some social skills at the same time during the group. So I think that's one of the important things of being in a group program, is interacting with other teens their age and hearing from other teens. So.
Yeah, thank you, Nicole. And yeah, I just really want to emphasize I'm really proud of our program and our staff in particular. Like we've done a really great job in terms of starting with what Rathas and Miller created and then really iterating on it. I think we're on our third or fourth version of the curriculum. We're constantly reviewing it on an almost weekly basis. We're adapting, to feedback from the youth that have participated in the program, what we find being helpful. Another thing is a number of us are formally trained in dialectical behavior therapy, myself and Nicole and some of our other staff. And so it's really great for us to be able to have our curriculum as sort of this living document in a way. We've done a lot in terms of adding a lot more interactive features to it, art and expressive treatment, group projects, things like that. So I think we've made it a lot more fun and engaging, and we're constantly trying to make it even more engaging, because if it's more engaging, the kids are more interested and it's more effective for them. And so this is something that I'm really excited about for our program. So talking about, in addition to group therapy, each youth is also offered individual therapy. As Nicole mentioned, youth can have individual therapy where they get pulled out of a group if they're only able to come on the IOP days. However, if they are able to do individual therapy on either a Tuesday or Friday, then they can have a little bit more time for individual therapy. And I am currently actively working on where we could do individual therapy over telehealth if, for example, youth aren't able to come in on the off days. The program itself, the groups are going to be in person, but having the flexibility to do individual therapy via telehealth, I think could be really helpful. So just some of the concepts in dialectical behavior therapy, for those of you who may not be familiar with it, as Nicole had mentioned, DBT originally designed for folks that are struggling with suicidality, self-harm behaviors, emotions that go up and down really fast. And this core concept of dialectics, or this idea of two seemingly opposite things can be true at the same time. And so DBT's main dialectic is this idea of a balancing acceptance and change. On one hand, we want to accept youth where they're at. We want to validate them and their experiences. And at the same time, we want to help them change and recognize that they could do things in life better. And really, it's better for them. One of the assumptions that we make in DBT is that everyone is doing the best that they can, and at the same time, they can do better. Again, going back to that dialectic of they're doing the best they can, because this idea of some people would be like, well, are they really doing the best they can? Quote unquote, they're being lazy or they're being manipulative or things like that. And what I say is, well, yes, they are doing the best they can with the knowledge and skills that they have. Oftentimes, youth are engaging in maladaptive skills. This idea of they have adapted to the world that they've grown up in. It just so happens that those adaptations are ending up causing negative consequences for them. And so, how do we help them adapt to their environment in a better way? And ultimately, the goal of DBT is to help individuals create a life worth living. And that's not how I define a life worth living, how Nicole defines a life worth living. It's how the youth defines a life worth living. And I'll be honest, sometimes they struggle with coming up with that definition. And maybe if they don't have that at the beginning of IOP, it is really our goal over the 12 weeks to help them get to that definition of what is a life worth living for them. Another key component of working as a DBT team is this idea of a consultation team. As we all know, or I'm assuming many people in this audience may know, that working with youth that have really volatile emotions, are chronically suicidal, engaging in maladaptive behaviors, they can be really challenging to work with. I think it's fair to be honest about that. It can also be exhausting, particularly if you're trying to do it on your own. And so we work as a team. Our staff, it's very small. There's 4 of us at the moment. I am hiring for a master's level therapist at the moment. So just throwing that out there, if you're listening to this in November of 2025, you can look on MultiCare's site for that posting. But we're a small group, but we work very closely. We meet at least once a week, oftentimes multiple times a week. And we talk about every youth that is in the program, and we problem solve together some of the challenges that they may be having, right? Are they, falling asleep in group? How can we help them? Is the individual therapist running into some barriers in individual therapy? Okay, how can we work on that? Is the therapist that's running the parent group, is there some friction among the parents? Can we brainstorm together how to solve that? And so we are providing support for each other. And by doing that, it helps us provide better treatment for the youth and their families that are enrolled in the program.
So for the parent DBT skills group, that's meeting Tuesdays for 5 o'clock to 7. I think it's really important if parents can attend. Of course, some can't. I understand there's, some parents have other kids or different, they have work, or some of them have transportation barriers. And so if they can attend, it's led by our therapist here, an individual therapist who's really excited and got a lot of great ideas. And so we're really excited for parent groups. So it's once a week, and is very supportive for parents, but also they're learning the DBT skills that their child is learning in basically the same order at the same time. So they're not only do they get to learn the skills so that they can practice them for themselves, but they are modeling them at home for their child, which I think is really important. And also, it's not just the adolescent that is working on things, right? It's not just the adolescent that is having issues or problems or life challenges. It's also happening in the home with others in the home. So if only the kiddo is changing, that's not going to change things in life and in the home. So it's really important for parents to practice these skills, know these skills, but also during this time, they're learning the language of DBT, right? Because there are, for those of you that do know, and for those of you that don't also, there are a lot of DBT acronyms, and there are a lot of different DBT terms and DBT skills. So when I talk to parents, most of the parents go, I don't even know what DBT stands for. I don't know what DBT is. some of them go, I don't know what IOP is. And so they're learning what these different terms are, what the different acronyms stand for, that their kids are learning, so that they can not only model and practice these skills at home, but also talk to their kids about it, or begin to talk to their kids. A lot of these parents are not having that kind of connection and relationship with their child. And they might not have it in that 12 weeks, but, working towards something, or at least knowing what their child is doing here, and then working on these skills for themselves. So I think that's really important. It's also important that it is a group, and so they feel supported. Now it's not a group where they come here and ask specific questions, like about their own child, like an individual therapy in a group, and talk about like a really specific thing that might have happened and get into that. It's not like that type of support group. It's a skills group, right? But at the same time, you'll have time for them to, there are several questions that I hear often from parents that we will talk about in a general way of answering those questions. So that will be good too. I think that'll be really supportive for parents to hear answers to some of the questions that I get, we hear often from parents. So that'll be supportive for them as they're learning these skills. So do you have anything to add to that, Dr. McIntyre?
No, sounds great. So going on to the next piece, medication management. So after my initial intake, I provide the youth and the family with the option of managing the youth psychiatric medications while they're enrolled in our program. Now, if they have, a current psychiatrist or psych nurse practitioner that they're very comfortable with, they want to continue with, but they have that option. They can continue. I don't need to be involved in the medications. Oftentimes what I share with them, though, is that there's a lot of advantages for me managing medications. One, I have the advantage of being able to get to know the kids pretty well and actually spend a fair amount of time with them. In addition to doing medication management and the intakes, I also run a couple groups a week. Usually at least one, but sometimes up to a couple of groups a week. And so I'm seeing them in a different setting than maybe most people who are prescribing medications will be able to see them, right? I'm seeing how they're interacting with me, other adults, how they're interacting with peers. And so that can be really helpful from a diagnostic standpoint, and can really help with me offering a second opinion. Oftentimes we have youth coming in, as well as parents being like, there's something missing from the diagnostic piece for me. I feel like I'm not completely understood. And so oftentimes I can provide that second opinion. Also, I do a very thorough review of a youth's medication history. And for some of our youth, that can be a very long history. And so I take a detailed history with the youth and the guardian, and often gives me an idea of what is something else that we can do. And oftentimes that is not adding medication. I am a minimalist when it comes to medication. And so oftentimes it's how can we consolidate your medication? Maybe we can streamline it, get you on less medications with less potential side effects. And the benefit of doing that in this setting is that we're also combining it with adding therapy, right? Adding skills. And so the more skills that they have, potentially they may need less medication. And so I will prescribe medication for their duration of treatment. I'll give them an extra month afterwards as they transition to outpatient care after here. And also if I have additional ideas of what they may do in the future with medications, whether that's adjusting doses or perhaps other medications to consider, I will include that in the discharge summary for future providers to consider.
All right, so talk about discharge planning a little bit more. I know I mentioned some of this, or so we do coordination of care work with other clinicians and service providers. I did think of something as far as individual therapy that I didn't mention before that I think is really important to mention. And so while youth have individual therapy here with their therapist, we do offer they can continue with their therapist. Now, as we're a really small team right now, and as Dr. McIntyre mentioned, that we are looking to hire master's level therapists. He is also providing therapy right now. So with the exception of him and myself, who's also providing therapy right now, I believe that we're not going to continue to offer outpatient therapy services on Tuesday and Friday, but with our therapist that's here, that's providing individual therapy for IOP patients, she is offering individual therapy on Tuesday and Friday, so they could continue with that with her as their therapist after IOP. And so that is an option if they wanted to reach her, if they have a therapist that they're seeing or that they were seeing before IOP, that would be an option for them to return to that therapist. And there are a lot of kiddos that come in that haven't been in therapy recently or at all. And so I will work to set up weekly therapy for them if that's the next step. Whatever the next step is, we'll all work together with them, of course, to set up the next step for after IOP. And then if it's, I would say if it's warranted, but if it's applicable, then I will work to set up psychiatric medication management for them, make sure they have an appointment. Some of them already have psychiatric medication management, as we have mentioned. So make sure that there's an appointment for that for after their discharge date, and then a follow-up with their behavioral health follow-up appointment with their primary care or their pediatrician for within 30 days after their discharge date. We do send right after graduation discharge a comprehensive discharge summary out to their next levels of care. And then, as I've said before, while they're here, we're collaborating and having coordination of care with all of their current clinicians. We do reach out in the beginning to their previous therapists if they've just recently stopped, like say discharged from their recent therapist as well. So I think that's it for discharge planning. And go on to this next slide here, which is our referral form. And so if anybody doesn't have the referral form, I can go ahead and get this to you. Just go ahead and email me. I will send you answer any questions anytime, and send you the referral form as well as like our informational flyer. And I'm always happy to talk about the program, answer questions for families, patients, kiddos. And so this is our referral form here. You can email it to me. I have a fax number. It's not on there, but we do have a fax. You can fax it to me. We will need recent mental health records at some point, hopefully with the referral form or soon after. And anybody, so I get asked this all the time, families can self-refer. I have gotten a referral form from a kiddo before. And so anybody, it doesn't have to be like primary care or clinician that refers. So yeah, I think the more information that's on there, the better, as long as it's, don't need everything on there, but to help Dr. McIntyre make a determination for, to accept or decline. Again, there's the exclusionary criteria right on there, but if you have any questions about that, I'd rather like have somebody ask me than just think, oh, okay, they're going to be declined. Please just reach out and ask me about it. Yeah.
Thank you, Nicole. So go ahead.
Oh, I was just gonna say, so that we're located inside the Greater Lakes Mental Health Building in Lakewood. We're at the Child and Family Door 1 entrance. And this is how to make a referral. There is my phone number there, my email address, and please email me if you'd like any more information. If you'd like me to send you the referral form, please share it with anybody that you think would benefit from having that information. And yeah, I would love to chat with anybody that would like some more information. So thank you so much.
Awesome. Thank you, Nicole. And yes, thank you everybody for attending. Really appreciate it. And we're really excited to be bringing this service to Pierce County.
Very excited. I think this is often one of the most requested services when we have Kids Mental Health Pierce County multidisciplinary team meetings is our options either to step in one direction, up or down. I like how you frame that. Thank you so much, Lucas and Nicole. I'll give it a moment, see if there are any questions in the chat or the question and answer. Would this be considered a least restrictive alternative to CLIP?
Potentially, it would have to be on a case-by-case basis. Oftentimes, if kiddos are being considered for CLIP, we may not be able to necessarily provide the level of care that they need. But again, it is on a case-by-case basis. I'm just thinking of my experience rotating at CLIP as a medical student and resident, and oftentimes the kids that we were working with there required more active behavioral management than we're necessarily able to provide here in IOP. As mentioned, we are a small team and we are in an outpatient setting, so we don't necessarily have the same level of environmental safety measures that may be needed for some youth. But again, if there's any questions, you can always feel free to send over a referral and we can always review it.
Thank you. Other questions? All right. Well, thank you. Again, Kids Mental Health Pierce County and Marybridge Children's MultiCare are very grateful and excited about this program. My contact information is here as well. I know Nicole is always willing to answer questions and really easy to contact. So you could reach out to myself to connect or directly to her if you have additional questions. And we are so grateful to have you here in Pierce County.
Thank you very much, Vanessa. Always great being welcome into the Kids Mental Health Pierce County community, and really appreciate the collaboration.
Great. We'll put this on the Kids Mental Health Pierce County website if you want to share it with any colleagues and really advertise and let folks know, because this is incredible. So thank you so much and have a wonderful day.
Thank you. Really appreciate it.
Thank you.